For individuals navigating their golden years, specifically those over the age of 70, a routine scheduled screening test from your doctor, seemingly innocuous and preventative, could paradoxically set in motion a chain of events that actively undermines your health and well-being rather than safeguarding it. This assertion stems from a deep, first-hand understanding gained from a vantage point at the very end of the medical labyrinth, the operating room. As an anesthesiologist for 15 years, I, Dr. Traz, have stood beside countless patients over 70, managing their vital signs, their consciousness, and their vulnerability as they undergo procedures that, with chilling frequency, should never have been initiated. These are not fringe or obscure tests. Rather, they are 5 common medical checkups that doctors, often with the best intentions, order automatically for patients in this age bracket, presenting them as responsible, prudent, and good medicine. They sound beneficial, but their true impact, particularly for the elderly, is often quite the opposite. These seemingly routine screenings can subtly, almost imperceptibly, lead you down a perilous path toward invasive procedures, unnecessary interventions, and debilitating complications that inflict more harm than any perceived benefit. My daily reality offers an unobstructed view of the devastating aftermath when these routine tests find something. What follows a positive screening result for an older adult is often a cascade of further investigations, biopsies, surgeries, and other aggressive interventions. A significant and frankly alarming number of patients over 70 are undergoing procedures they simply never needed. These interventions often originate from screening tests that, in retrospect, should never have been ordered in the first place. By the time these patients are transferred to my operating table, the initial damage has frequently been done. The insidious cascade has begun, and I find myself managing preventable complications such as post-operative confusion, urinary retention, infections, and prolonged recovery periods. My role then shifts from merely providing anesthesia to navigating the treacherous waters of systemic dysfunction, compounded by the patient's already diminished physiological reserves. Today, my aim is to illuminate 5 specific health checkups that, for those beyond 70, frequently cause more harm than good, explaining precisely why they pose a danger, what the consequences of a positive finding truly entail, and crucially, how you can confidently engage with your doctor to protect yourself from this often well-intentioned but ultimately detrimental paradigm. The medical system, by its very design and inherent philosophy, is meticulously structured to screen, to test, and relentlessly to find problems. This approach serves a vital purpose for younger populations, where early detection and aggressive treatment can genuinely extend life and improve long-term outcomes. However, a profound and often unacknowledged shift occurs after the age of 70. At this stage of life, the act of finding problems frequently creates far bigger, more immediate, and more impactful problems than the original, often indolent, issue itself. To safeguard your health and quality of life, it becomes imperative to understand which tests to politely but firmly decline. But before we delve into the specifics of which screenings to avoid, it's fundamental to grasp a core principle about how medical testing functions in the context of advanced age, a nuance doctors often fail to explain with sufficient clarity. The crucial alteration that transpires after 70 years of age centers on the very purpose of screening tests. These tests are fundamentally engineered to detect disease at its earliest stages, when therapeutic interventions hold the greatest potential to extend a patient's life. This framework operates beautifully for someone in their 50s. Discovering an early-stage cancer, treating it aggressively, and subsequently enjoying an additional 20 or 30 years of healthy life represents a clear, quantifiable benefit. The mathematical equation for risk versus reward works convincingly. However, when we apply the identical logic to an individual who is 75 or 80 years old, the mathematical calculus undergoes a complete and dramatic transformation. We begin to identify diseases, particularly certain cancers, that are characterized by an exceedingly slow rate of progression. These are often cancers that might take 10 or even 15 years to manifest as symptomatic problems or to pose a genuine threat to life. Statistically, it becomes highly probable that something else, perhaps a pre-existing chronic condition, a cardiovascular event, or simply the natural decline associated with advanced age, will impact that individual's health and lifespan long before such a slow-growing cancer ever does. Herein lies the insidious trap of the modern medical system. Once a screening test unearths an abnormality or finding, it cannot be simply unfound. The gears of the medical machine are already engaged, built to investigate, to biopsy, and ultimately to treat. Each successive step in this rigorous investigatory process carries its own intrinsic and escalating risks. A biopsy, for instance, might trigger bleeding, lead to a serious infection, or cause pain and discomfort. The subsequent treatment, whether it be surgery, radiation, or chemotherapy, invariably brings with it a host of potential side effects, from fatigue and nausea to more severe life-altering complications. And if you are over 70, your body's intrinsic capacity to withstand and recover from these complications is markedly reduced. You no longer bounce back with the same resilience and vigor you once possessed. I have, on numerous occasions, placed patients in their 80s under general anesthesia for biopsies of incredibly slow-growing prostate cancers, cancers they would almost certainly have outlived. The tragic irony is that these patients subsequently developed post-operative confusion, sometimes manifesting as debilitating delirium, coupled with urinary complications and infections. All of these adverse outcomes stemmed from the investigation of a condition that, in all probability, was never going to be the ultimate cause of their demise. The initial screening test, designed to protect, unwittingly initiated a cascade of events that these individuals and their exhausted families found themselves utterly powerless to halt. They frequently ended up in a significantly worse state than if the problem had never been discovered in the first place. Therefore, the pertinent question for individuals in this age demographic shifts fundamentally from should we find problems to a far more nuanced query: should we actively seek out problems where the very act of finding them creates more harm than the problem itself? And after the age of 70, for specific, widely ordered screenings, the unequivocal answer is often a resounding no. Now let me detail which screenings fall into this critical category. Number 1, routine colonoscopy after 75. This particular screening is arguably the most significant and certainly the most contentious, largely due to the pervasive and aggressive promotion of colonoscopy as an essential pillar of preventive care for decades. It has been ingrained in public consciousness as the gold standard for colon cancer prevention. However, a dispassionate examination of the empirical data reveals a stark reality. The tangible benefit of colonoscopy, specifically for colon cancer screening, diminishes dramatically after an individual reaches the age of 75. Most contemporary medical guidelines, having assimilated this evolving evidence, now explicitly recommend ceasing routine screening at ages 75 to 80, with the precise cutoff often contingent upon the patient's overall health status and their past screening history. The underlying physiological rationale for this shift is straightforward. Colorectal cancer typically develops at a slow, gradual pace. Precancerous polyps require years, often a decade or more, to undergo malignant transformation and become cancerous. Consequently, if you have diligently undergone routine colonoscopies throughout your 60s and early 70s, consistently yielding normal results, your inherent risk of developing a rapidly progressing, life-threatening colorectal cancer after 75 is already remarkably low. Statistically, discovering a new, aggressive cancer after this age that would genuinely and significantly shorten your remaining lifespan is an uncommon occurrence. Yet, while the benefits of detection wane, the inherent risks associated with the colonoscopy procedure itself demonstrably increase with age. Many patients and even some practitioners fail to fully appreciate the multifaceted risks involved The preparation for a colonoscopy, which involves consuming powerful laxatives over 1 or 2 days, induces a state of sustained, severe diarrhea. For an elderly patient, this is not merely an unpleasant experience, it can be profoundly dangerous. It frequently precipitates severe dehydration, disrupts the delicate balance of vital electrolytes such as sodium and potassium, and can cause dangerously precipitous drops in blood pressure, leading to dizziness, falls, and potential organ damage. I have personally witnessed patients admitted to the hospital solely due to the debilitating and life-threatening complications of the bowel preparation itself, requiring intensive medical stabilization before the actual procedure could even be contemplated. Then there is the procedure itself. The vast majority of colonoscopies performed on patients over 70 necessitate some form of sedation, commonly utilizing propofol, which I, as an anesthesiologist, am responsible for administering. And as I have frequently emphasized, general anesthesia and deep sedation after the age of 70 carry a distinct and elevated set of risks. These include, but are not limited to, post-operative cognitive dysfunction, often manifesting as delirium, significant breathing complications, and considerable cardiovascular stress on an aging heart. Patients are unwittingly accepting these very real and potentially severe risks to look for something that is statistically highly unlikely to impact their remaining quality of life or overall longevity. Moreover, should a polyp be discovered during the procedure, it automatically triggers further interventions, such as biopsies or polyp removals. These interventions, while necessary if a polyp is found, themselves carry risks, including bleeding or, in more severe cases, perforation of the colon wall. I have managed patients through emergency abdominal surgery for perforated colons, a catastrophic complication directly resulting from a routine colonoscopy. In such tragic instances, the screening test, ostensibly designed to prevent cancer, culminates in a life-threatening surgical emergency, demanding an arduous recovery that profoundly impacts the patient's independence and overall quality of life. Even reputable organizations, such as the American Cancer Society, now acknowledge that for individuals with an average risk profile and a history of previous normal screenings, discontinuing routine colonoscopies at 75 is a perfectly reasonable approach. For those with significant pre-existing health conditions or a notably limited life expectancy, stopping even earlier is medically prudent and makes logical sense. Despite this evolving guidance, doctors continue to order these tests automatically, and patients, trusting their physicians, implicitly assume they should comply. Consequently, they undergo screenings where the potential harm frequently outweighs any conceivable benefit. But colonoscopy is far from the sole screening that warrants critical reevaluation after 70. The landscape of cancer screening, in particular, holds further surprises. Number 2. Aggressive breast and prostate cancer screening. Let us now turn our attention to cancer screenings, specifically routine mammograms for women and PSA, prostate-specific antigen, tests for men, particularly after the age of 75 or 80. These screenings are deeply embedded in the contemporary practice of preventive medicine, almost sacrosanct in their perceived importance. However, the scientific evidence supporting their indefinite continuation into advanced old age is surprisingly weak, and the potential for substantial harm is very real. For breast cancer screening, most established guidelines suggest that women should consider discontinuing routine mammograms somewhere between 75 and 80, particularly if they are grappling with other serious, life-limiting health conditions. The rationale behind this recommendation is critical to understand. As women age, we increasingly begin to detect breast cancers that are characterized by an exceedingly slow growth rate. These are cancers that, statistically, would never progress to cause symptoms, nor would they pose a threat to an individual's remaining lifespan. The term for this phenomenon is overdiagnosis. However, once such an indolent cancer is discovered through screening, the medical system is ill-equipped to unfind it or to simply ignore it. The process is then set in motion, biopsies are performed, and if cancer cells are confirmed, the default response is often aggressive treatment, surgery, lumpectomy or mastectomy, radiation therapy, and potentially chemotherapy or hormone therapy. I have personally administered anesthesia to women in their 80s for lumpectomies or even mastectomies for what pathology later confirmed to be incredibly slow-growing early-stage breast cancers. While the surgical procedure itself might be technically successful, the subsequent recovery can be profoundly challenging for an elderly patient. Weeks of persistent pain, debilitating fatigue, and a significant reduction in their baseline independence are common. And for what ultimate purpose? To treat a cancer that, according to epidemiological data, would statistically not have influenced their overall lifespan. Yet, because the screening test detected it, it was treated. The tragedy here is that the aggressive treatment itself, with its myriad side effects and arduous recovery, reduced their quality of life far more significantly than the detected cancer ever would have. For men, PSA screening for prostate cancer is even more steeped in controversy. Prostate cancer is in fact extraordinarily common in elderly men. Autopsy studies consistently reveal that a significant majority of men over the age of 70 harbor some prostate cancer cells. Crucially, most of these cancers are clinically insignificant. They grow so slowly or not at all that they never cause symptoms or progress to become a life-threatening problem. However, PSA screening is designed precisely to detect these cells, and an elevated PSA level invariably leads to the recommendation for prostate biopsies. I regularly anesthetize men for these biopsies. These procedures, while seemingly minor, carry their own set of risks: bleeding, infection, which can be severe, leading to sepsis, and urinary retention. And if the biopsy confirms cancer, the patient is immediately confronted with discussions about aggressive treatment options, radical prostatectomy, surgery, radiation therapy, or androgen deprivation, hormone therapy. All of these interventions are associated with significant and often life-altering side effects, including permanent incontinence, erectile dysfunction, and pervasive fatigue, which collectively erode a man's quality of life and independence. The U.S. Preventive Services Task Force, USPSTF, after a comprehensive review of the scientific evidence, now explicitly recommends against routine PSA screening in men over 70. Their conclusion is unequivocal. For this age group, the harms associated with screening and subsequent treatment demonstrably outweigh any potential benefits. Despite this clear guidance from a leading independent body, many doctors continue to order PSA tests, and a significant number of men still undergo them. I continue to see these men on my operating table, undergoing procedures for cancers they often did not need to know about and certainly did not need to treat. It is vital to clarify, I am not advocating for a universal cessation of cancer screening after 70. What I am emphasizing is that the decision-making process for screening needs to be profoundly individualized, moving away from an automatic one-size-fits-all approach. If, for instance, you are 72 years old, in genuinely excellent health, and your projected life expectancy reasonably includes another 15 or 20 robust years, then continued screening for certain cancers might still be a prudent choice, made in careful consultation with your physician. However, if you are 80 with multiple coexisting health conditions that significantly impact your daily life and prognosis, then continued aggressive screening is demonstrably more likely to cause harm than benefit. This is the nuanced, personalized conversation that you absolutely must have with your doctor. A move away from automatic, protocol-driven screening towards shared, informed decision-making tailored to your unique circumstances and priorities. Yet, cancer screening is not the only domain where more testing often begets more problems. The next screening I will discuss frequently leads to one of the most common unnecessary procedures I encounter. Number 3, routine cardiac stress testing. This particular screening is a source of profound frustration for me, largely because I bear witness to its pervasive and damaging downstream effects on an almost constant basis. The scenario often unfolds like this: a patient over the age of 70 exhibiting absolutely no cardiac symptoms, no chest pain, no shortness of breath, no unusual fatigue, presents for a routine physical examination. During this visit, the doctor, acting with what they perceive to be an abundance of caution, orders a cardiac stress test simply to be safe. The stress test is then performed and, as often happens, it reveals some form of abnormality. Critically, this abnormality is not indicative of an active heart attack, nor does it typically point to a dangerous, life-threatening arrhythmia. Instead, it might show subtle ST segment changes on an electrocardiogram or minor perfusion defects on an imaging study, findings that, in isolation, might signify absolutely nothing or, conversely, could suggest a mild underlying issue. However, once such an abnormality is flagged, the cardiologist, compelled by the investigative imperative of the system, invariably seeks more information. This almost universally leads to the ordering of a cardiac catheterization. This is a significantly more invasive procedure where a thin, flexible catheter is carefully threaded through your blood vessels, typically from the groin or wrist, all the way into your heart, enabling direct visualization of the coronary arteries. And predictably, who is managing the crucial sedation for this invasive procedure? It is I, the anesthesiologist. Cardiac catheterization, despite its commonality, is far from risk-free. It carries a spectrum of potential complications: bleeding at the insertion site, which can be severe, a small but real risk of stroke from dislodged plaque, kidney damage from the iodinated contrast dye used to visualize the arteries, and in rare but catastrophic instances, a heart attack or even death. While these individual risks may be statistically small, they are unequivocally not zero, and the patient is accepting these very real risks solely because a screening test performed on an entirely asymptomatic individual yielded an abnormality that may or may not be clinically significant. The cascade frequently continues. The cardiac catheterization might indeed reveal some blockages in the coronary arteries. Crucially, these are typically not complete occlusions, nor are they immediately life-threatening. They might be described as 60% or 70% narrowing in one or two vessels. At this juncture, the discussion inevitably pivots to interventional procedures, either placing stents to prop open the narrowed arteries or, in more severe cases, recommending bypass surgery. As I have elucidated previously, the impact of general anesthesia and major surgery on patients over 70 is profound, and the attendant risks are substantial and well documented. Yet, the critical data point often overlooked in these discussions is this: for people who are entirely asymptomatic, without any signs or symptoms of heart disease, finding and subsequently fixing these blockages through stenting or bypass surgery has been consistently shown across multiple large-scale, robust studies, such as the landmark COURAGE trial and the more recent ischemia trial, to not improve lifespan or prevent future heart attacks any more effectively than optimal medical management alone, which involves diligent adherence to medications and lifestyle modifications. So, if the evidence clearly indicates no benefit in terms of longevity or prevention of future cardiac events, why are these procedures so routinely performed? The answer lies in the deeply entrenched find and fix mentality. Because we found it, the system dictates it must be addressed. The initial screening test, meant to provide reassurance, instead initiated an unstoppable cascade of investigations and interventions. Once an individual enters this intricate system, it becomes remarkably difficult to disembark. It is worth noting that organizations like the American College of Cardiology and the American Heart Association do not recommend routine stress testing in individuals who are asymptomatic, regardless of their age. Despite this expert consensus, this practice continues unabated, and I regularly encounter these patients in the recovery room, recuperating from invasive procedures they demonstrably did not need, sometimes grappling with complications that fundamentally alter the trajectory of their lives. But the realm of cardiac testing is not the only area where the pursuit of findings creates more problems than it solves. The next screening I am about to detail concerning bone density might fundamentally shift your perspective on the standard approach to osteoporosis treatment. Number 4, routine bone density scans, DEXA scans. Bone density scans, commonly known as DEXA, dual energy X-ray absorptiometry scans, are broadly recommended for women over 65 and men over 70 as a routine screening tool for osteoporosis. On the surface, this recommendation appears entirely logical and well-intentioned. The overarching goal is to identify individuals at risk of fractures, particularly debilitating hip fractures, which can be catastrophic for elderly patients, frequently leading to a profound loss of independence, increased mortality, and significant suffering. However, the application of this screening and its subsequent management becomes considerably more complex and problematic as individuals advance into their later years. The detection of low bone density through a DEXA scan often leads almost automatically to the initiation of pharmacological treatment, primarily with medications such as bisphosphonates, e.g., Fosamax, Beniva. While it is true that these drugs do offer a modest reduction in fracture risk, they are not without significant and often underemphasized side effects. These can include esophageal irritation, severe musculoskeletal pain, and, with long-term use, rare but serious complications such as atypical femur fractures, fractures of the thigh bone that occur with minimal trauma, and osteonecrosis of the jaw, ONJ, a painful and debilitating condition that can be exacerbated by dental work. The crux of the issue, particularly for individuals over 80, and especially those who are frail or experience limitations in their mobility, is that the measurable benefit of these medications significantly decreases. This is because fracture risk in the very elderly is determined by a confluence of factors far more complex than just bone mineral density alone. The predominant driver of fracture risk in this demographic is, in fact, fall risk. Frail elderly patients fall not solely because their bones are less dense, but because of a multitude of interacting factors: impaired balance, muscle weakness, visual deficits, neurological conditions, and, critically, polypharmacy, the use of multiple medications that can cause dizziness, drowsiness, or postural instability. Treating their bone density with pharmaceutical interventions, while potentially addressing one aspect of the problem, fundamentally fails to address these more immediate and pervasive issues contributing to their propensity to fall. Moreover, if one is 85 years old and living with multiple serious chronic health conditions, preventing a potential fracture that might occur in 5 or 10 years is not necessarily the most salient or appropriate clinical priority. At this stage of life, the paramount concern often shifts decisively towards preserving and enhancing immediate quality of life, maintaining functional independence, and minimizing discomfort. Taking medications that carry a tangible risk of side effects, even if rare, can actively detract from this immediate quality of life. I am certainly not suggesting that osteoporosis should never be treated. Rather, I am asserting that the routine application of screening and the automatic initiation of treatment, especially after the age of 80, demands rigorous questioning and a highly individualized approach. The clinical conversation should fundamentally revolve around comprehensive fall prevention strategies, incorporating strength and balance training, a meticulous review of all medications to identify and eliminate drugs that heighten fall risk, and addressing environmental hazards. It should not simply default to automatically prescribing bone density medications solely because a scan revealed low numbers, without considering the broader context of the patient's health and priorities. But there remains one more pervasive screening that I frequently observe leading to invasive procedures, which, with distressing regularity, cause more harm than genuine benefit. This particular test is ordered with astounding constancy. Number 5, carotid artery screening. Carotid artery ultrasound screening is a diagnostic procedure designed to detect blockages or narrowing stenosis in the carotid arteries located in your neck. These vital arteries are responsible for supplying blood to your brain. The theoretical premise behind this screening is intuitively appealing: to identify these blockages proactively before they can lead to a devastating stroke, and then to surgically correct them. On the surface, this sounds like an eminently reasonable and responsible approach to preventive medicine. However, a critical problem emerges when this screening is applied to individuals who are entirely asymptomatic. That is, people who have no history of stroke, transient ischemic attacks, TIAs, or mini-strokes, or any other symptoms suggestive of cerebrovascular disease. In this asymptomatic population, routine carotid screening frequently identifies blockages that are, in fact, causing no problems whatsoever. The robust scientific data unequivocally demonstrates that surgically intervening to fix these asymptomatic blockages does not prevent future strokes any more effectively than diligent medical management alone, which typically involves the use of blood thinners and cholesterol-lowering medications. Despite this clear evidence, once a 70% or 80% blockage is identified on an ultrasound scan, the prevailing tendency within the surgical community is often to proceed with intervention. This intervention typically takes one of two forms, either carotid endarterectomy, which is an open surgical procedure to physically remove the plaque buildup from the artery, or carotid stenting, a less invasive procedure where a stent is deployed to prop open the narrowed vessel. Both of these procedures necessitate anesthesia, and both carry inherent and significant risks. These risks include the very outcome they are designed to prevent: a stroke occurring during the procedure itself, a heart attack, significant bleeding, or nerve damage to structures in the neck. I have personally managed countless patients through these carotid procedures, and I have, with profound regret, witnessed the devastating complications firsthand. I have seen strokes caused by the very surgery intended to prevent them. I have cared for patients who were perfectly healthy and functionally independent before the screening, living their lives without any cerebrovascular symptoms, who subsequently emerged from a procedure with new neurological deficits. A cruel irony when the goal was prevention. The U.S. Preventive Services Task Force, USPSTF, after a thorough review of all available evidence, recommends against screening for carotid artery stenosis in people who are asymptomatic. Their conclusion is clear. For this population, the potential harms of screening and subsequent intervention demonstrably outweigh any potential benefits. Despite this unequivocal recommendation from a leading authority, carotid artery screening regrettably continues to be a common practice. It is often bundled as part of vascular screening packages, aggressively marketed at health fairs or through direct-to-consumer advertising. Patients, understandably believing they are being proactive and responsible stewards of their health, are thus drawn into a cascade of testing and potential interventions that, more often than not, can inflict profound and lasting harm. Now that you are informed about the 5 specific screenings to critically question after 70, you are likely pondering the more fundamental question: why does this pervasive cycle of potentially harmful overscreening continue unabated? Why do doctors, despite their Hippocratic oath to do no harm, so frequently order tests that demonstrably cause more harm than help in this particular age group? There are several complex and interwoven reasons contributing to this systemic issue. Firstly, the very core of medical training instills in physicians a powerful directive to diligently find problems and then to assiduously fix them. We are meticulously trained to detect pathology, to diagnose, and to intervene. The concept of not looking or observing without intervention, particularly for something that sounds ominous like cancer or heart disease, is fundamentally counterintuitive to our ingrained professional ethos. It requires a significant paradigm shift in thinking, a discomfort with inaction that goes against years of conditioning. Secondly, the pervasive climate of defensive medicine plays a substantial role. Doctors operate under the constant, looming shadow of potential liability. There is a very real and understandable fear of being sued if a physician chooses not to screen a patient, and that patient subsequently develops a serious illness that could have theoretically been detected earlier. This fear often incentivizes overscreening. Ordering every conceivable test becomes a defensive strategy, a way to demonstrate that everything possible was done to cover oneself legally, rather than solely prioritizing the patient's best clinical interest. The potential for litigation often overrides nuanced clinical judgment, particularly in complex age-related scenarios. Thirdly, undeniable financial incentives are deeply woven into the fabric of the healthcare system. Screening tests, when positive, frequently lead to further diagnostic procedures, biopsies, consultations with specialists, and ultimately interventional treatments or surgeries. Each of these steps generates revenue for hospitals, clinics, and individual practitioners. While it would be unfair and inaccurate to suggest that doctors are malicious or consciously prioritize profit over patient well-being, the existing fee-for-service model inherently incentivizes testing and intervention. The system is simply not designed to reward thoughtful restraint or the difficult decision to do less. Finally, and perhaps most powerfully, there is significant patient demand and societal expectation. We, as a society, have been assiduously taught for decades that more screening equals better care. The narrative that finding problems early is always good has become an unquestioned mantra. Consequently, patients often arrive at their appointments actively requesting these screenings, believing they are being proactive and responsible. The concept that doing less might actually be better, or that finding a problem could lead to a net negative outcome, is incredibly counterintuitive and often met with skepticism or even outright rejection. Nobody wants to hear that inaction might be the most beneficial course of action. So, given these systemic pressures and ingrained beliefs, what steps can you, as an informed patient over 70, take to protect yourself from potentially harmful screening practices? First and foremost, cultivate the habit of asking incisive questions. When your doctor proposes or orders a screening test, do not merely accept it passively. Instead, engage them in a thoughtful dialogue. Ask, what precisely are we looking for with this test? What are the immediate and long-term consequences if we find something abnormal? What are the specific risks associated with the subsequent investigations, like biopsies, and any potential treatments that might follow? Given my current age, my overall health status, and my personal priorities, is this specific screening test truly likely to extend my life or meaningfully improve my quality of life, or might it inadvertently detract from it? This line of questioning forces a crucial pause and shifts the conversation from automatic protocol to individualized consideration. Second, make an effort to familiarize yourself with established guidelines. Most major medical organizations and professional bodies publish age-specific recommendations and cutoffs for routine screenings. These guidelines are often based on extensive data reviews and consensus among experts. Empower yourself by looking them up. Reliable sources include the USPSTF, American Cancer Society, American Heart Association, etc. And if you feel comfortable, bring this information to your medical appointments. This demonstrates that you are an engaged, informed participant in your own healthcare decisions. Third, consciously prioritize quality of life. If you are 75, 80, or older, your primary and most profound goal should be centered on maintaining your sense of well-being, preserving your independence, and, whenever possible, avoiding invasive procedures, hospitalizations, and the arduous recoveries they entail. The objective should not be to relentlessly uncover every conceivable medical problem that might exist within your body, especially if those problems are unlikely to cause harm within your remaining lifespan. A shift in perspective from disease hunting to life enhancing is critical. Fourth, actively seek out a doctor who practices conservative medicine. Not every physician adheres to this philosophy, but there is a growing movement towards more judicious, patient-centered care. Look for a doctor who explicitly understands and embraces the nuanced principle that, after a certain age, a less aggressive, less interventional approach is often demonstrably superior. These physicians exist, and they are unequivocally worth the effort to find. They will be partners in shared decision-making rather than solely prescribers of tests. And finally, and perhaps most crucially, always remember this fundamental truth. You possess the inherent right to decline medical testing. You are the ultimate arbiter and sovereign over your own medical care. If a screening test, after careful consideration and thoughtful discussion, simply does not make logical or intuitive sense for you and your personal health goals, you have every right to politely but firmly say no and then confidently move forward with your life. I am sharing this deeply personal and professional insight with you because I am uniquely positioned at the endpoint of this medical journey. I witness on a daily basis the profound consequences for patients who entered the medical system as relatively healthy, independent individuals, only to emerge damaged and diminished. not primarily by an underlying disease process, but by the relentless investigation of that disease, by the invasive procedures that were the direct, often unavoidable, result of screenings that, in retrospect, should never have been performed. This trajectory is not inevitable. It does not have to be this way. Medicine has the profound capacity to be practiced differently. We can, and indeed must, become more selective and discerning about who we screen, when we screen, and why. We must prioritize having honest, empathetic, and transparent conversations with patients about the genuine risks and potential benefits of every proposed intervention. And critically, we must consciously shift our collective focus to prioritizing quality of life over the exhaustive, often detrimental, pursuit of finding every possible physiological anomaly. However, this transformative shift requires an informed and empowered patient, a patient who is prepared to ask the penetrating questions, to understand the nuances, and sometimes, with conviction and grace, to say no. Therefore, if you are over 70 and your doctor casually suggests a routine colonoscopy, a PSA test, a cardiac stress test, a DEXA scan, or a carotid ultrasound, I implore you, pause, take a moment, ask why this test is being ordered for you, specifically. Inquire about the full spectrum of what happens next if the test returns an abnormal result. And most importantly, ask the most critical question. Is this specific screening, given my unique circumstances, truly likely to help me? Or is there a genuine possibility it could inadvertently hurt me? Equip yourself with this knowledge and engage in truly informed decision-making. Because screening after 70 is rarely automatically beneficial. It is a complex, nuanced endeavor, and there are countless instances where the very best screening, the most life-affirming decision, is no screening at all. If this vital information has resonated with you, if it has instilled in you the confidence to ask better questions or to thoughtfully decline unnecessary testing, I urge you to share this comprehensive message with someone over 70 who desperately needs to hear it. Leave a comment below, sharing which screening recommendation surprised you the most. Remember that informed patients are unequivocally better equipped to make decisions that truly serve their long-term health and well-being. You deserve to know the complete truth, not just the selective parts that encourage more testing.